Good evening to all. And I am Dr. Nupurai, we must be knowing, working as a head of Kalazar, entities, Kalazar, LF, and other assignment also are there. I have already mentioned in my mails and all. So today I'm very much thankful to the organizers of the core entity group for giving me this opportunity to speak. And I would also like to say that this is for the first time I am speaking in core entity, though I am working for these entities almost a decade in National Center for Vector-Borne Disease Control Program. So the subjects they have chosen are very interesting because this is the apt time to discuss the things to sustain the gains in the past, and so that India could be certified as eliminated. Like I am very much hopeful about that Michael Pullman's vector surveillance and control in post-elimination era. And then Dr. Sridhar, option for case detection strategies for tracking VL elimination. And Mary Cameron's is more interesting, that development of a point of need tool, multiplex tool for integrated vector-borne disease surveillance. And Christine's diagnosis of VL in elimination setting. These are all very important and need of the award. So I welcome you all and thank you. We can start with our presentation, then we'll discuss how we can go forward this session. Thank you so much. Good evening to all from India. I am Dr. Nupur Roy, working as HOD for visceral leishmaniasis, lymphatic filariasis, Japanese encephalitis, and ICVCC at National Center for Vector-Borne Disease Control under Ministry of Health and Family Welfare, Government of India. First of all, I would like to extend my gratitude to the organizers of core entity, particularly Patrick and Vanessa, for coordinating with all the participants. I am working here since almost a decade, and as communicated earlier, I will be speaking about progress, achievement, remaining challenges, and way forward for Kala-Azar elimination in India. So this is the overview. You can see Kala-Azar endemic in 4 states in India: Bihar, UP, West Bengal, and Jharkhand. And 54 districts, and among these 54 districts, 633 blocks are endemic. And the definition is to reduce annual Kala-Azar case incidence to less than 1 per 10,000 population at block level. And I am glad to say that India is close to achieving elimination. That is evidenced by the total number of 633 endemic block by the end of 2021, 625, that is 98.7% endemic blocks have achieved the elimination status by the program strategies, that is early diagnosis and complete case management, integrated vector control and vector surveillance, supervision, monitoring and surveillance and evaluation, strengthening of capacity of human resource in health, advocacy, communication and social mobilization for behavioral impact and intersectoral convergence, and definitely program management. So now you can see the trend of VL cases and death trends from 2014 to 2022. In the year 2014, there were 9241 cases with 11 deaths. And by the end of 2021, there were 1357 cases with 26 deaths. And in 2022, 649 cases, death reported 23. This number of deaths have been captured from the CAMIs, and which are yet to be verified by the verbal autopsy report and death audit committee report by the respective states. Now, below you can see the scenario of PKDL, that is post-Kala-Azar dermal leishmaniasis. In 2013, you can see only 499 cases were there because at that time it was not included under Kala-Azar elimination program. Then while launching the roadmap for Kala-Azar elimination program in 2014, experts advised us to look into the PKDL, which acts as a reservoir.
Thank you, Dr. Roy, for that excellent introduction to the elimination program and a very good way to
Leslie, I think that the
I'm
presentation was
sorry.
not completed. That presentation was not completed. I think she has about 7 minutes of speaking, so only about 2.5 minutes or 3 minutes were over. Should I have a copy of that? Should I broadcast from here?
I think that would be good. Yes. The video that I received, it looks like ends at 2 minutes and 50 seconds.
Okay, let me try this.
Okay,
Let
thank
me.
you.
For me, the problem seems to be that I am not able to see the screen that I'm supposed to share. I have it open on my no. Yeah, I think I'm getting there. Just 1 second. Can you see the screen?
We can.
Yeah,
Yes.
we can see it.
Great, fantastic. Let me just start it now.
Good evening to all from India. I am Dr. Nupur Kala-Azar in 1000 case search, and which increased during 2017 almost 2000 cases, and then there is a decline, and and in 2022 till August there are only 411 PKDL cases reported. Right hand side you can see the block level elimination status of India. That is by end of 2021 only 8 blocks remained to achieve elimination, and as of now only one block, that is Littipara in Pakur district of Jharkhand, has crossed the endemicity limit. So these achievements, so everybody is talking about achievement of India, and I am also keeping my finger crossed that soon we'll be basking in the glory of eliminating Kala-Azar. And how it has become possible? Because of introduction of single dose treatment with liposomal amphotericin B, definitely WHO is donating this lamp. And availability of drugs and diagnostic at block level, high level ownership with political commitment at all levels, and Kala-Azar is notifiable disease in all 4 endemic states. And we did independent assessment in 2020 with international and national experts. We did situational analysis of the program in 2021, and there is real-time reporting of data through CAMIS, and financial incentive for early detection to ASHAs, wage-less compensation to the patients, awards and subnational level for achieving elimination to create healthy competition among the blocks, districts, and states, use of synthetic pyrethroid insecticide since 2015 and hand compression pump from 2016-17 for quality spray and vector control, construction of pakka houses in Kala-Azar endemic areas under different housing schemes, regular review and monitoring by central and state officers, technical expert groups and ministry, partner support at various intervention areas, and updated program guideline and SOPs are there, like accelerated plan, SOPs for ACS, outbreak investigation, operational definition. These are all uploaded in our website. And now remaining challenges are these persistent pockets. Definitely in the new emergence of new foci, new VL cases from non-endemic area, cross-border migration causing new foci of infection, and KHIV and KATB co-infection are also a challenge, and also surveillance of PKDL cases to sustain the elimination, confirmatory diagnosis for PKDL and relapse, gap between the onset of symptom to diagnosis, post-elimination surveillance and vector control, poor health-seeking behavior of the tribal and hard-to-reach areas population, and occurrence of PKDL cases which act as a reservoir infection is also very important. Now, way forward. To sustain the blocks already achieved elimination status, to achieve elimination that is less than 1 case per 10,000 population in the remaining block, enhance surveillance on persistent pockets of high endemicity and areas of new foci, capacity building of state and district VBD officials and consultants on early diagnosis and PKDL, establishing center of excellence, a new tool for diagnosis and treatment, continued commitment by various stakeholders including donors, validation and certification process for K elimination, saturation of K endemic villages by construction of pakka houses, engagement of other departments like rural development, water and sanitation, education department, PRI, etc. And now we can see we are having partners because they contributed a lot, and I hope they will be with us for the next period of journey and deal verification, that is sustenance period also, that BMGF, CARE, CFAR, CHAI, GHS, ICMR and RM RIMS, and LSTMH, PATH, PCI, and we must not forget the contribution of MSF, DNDI, Kalakor, and FRHS, who have contributed in an immense way earlier in VL program. So India is committed to eliminate Kala-Azar within 2023. Thank you for your patience hearing.
Thank you, Dr. Roy, for that
Dr.
excellent
Sridhar?
introduction, to
Dr. Sridhar?
Yes, Dr. Roy. Should we go ahead?
I think so.
Yeah, okay.
To all of you. I'm Sridhar from Care India. In India, we've been supporting the elimination program in the two worst affected states, Bihar and Jharkhand, for close to a decade. Based on that experience, I'll try and put forward in the next 10 minutes uh, a few thoughts on what we need to think of as we get into the next phase of the elimination program. As Dr. Roy mentioned, we are pretty close to elimination, although we have not interrupted transmission. Uh, there has been substantial support coming both from government investments as well as from development partners for a long time now. At the same time, we know that there are certain limitations of our tools, and that, as would be natural for any large program, there are lots of competing priorities. From a very practical perspective, the program needs to know, as it gets into the next phase of the elimination program, answers to a few practical questions. A, is Kala-Azar going to come back, likely to come back? B, where are the parasites hidden at present? Where are the reservoirs from where it's likely to re-emerge, if at all? What geographies are likely to be affected going forward? And in case there is a resurgence, do we have the tools? What tools are likely to help us tackle it? To the question, will Kala-Azar come back? The available incidence data seems to suggest that it's neither going to come back very soon nor in a big way. For instance, the current incidence is about 2% of what was there at the last peak in 2007. And it's also about 10 times less than what it was, let's say, in the year 2000, which was the last trough with about 10,000 cases. And we know that there was a lot of underreporting in that past period. So if even assuming that there were only 10,000 cases, if 10,000 cases as a reservoir gave rise to a peak of about 44,000 cases in 2007, we should not be expecting a very big peak starting now, even if it started. Second, the rate of decline was plateauing off until 2018, and we might have suspected that it would start going up sometime thereafter. However, thereafter, in fact, it has declined. It started going down at almost 2 or 3 times that the previous rate over the last 3 years. This would also suggest that it is on the downstroke and not really increasing any longer. A third indication is that lately, most affected villages are single case villages, unlike in the past, where we used to find a higher proportion of multi case villages each year. This phenomenon is reflecting in the proportion of cases each year that come from recently affected villages, where earlier around 55 to 60% of cases used to come from villages that had thrown up cases the previous year as well. This proportion has come down to less than 40% in 2021. Essentially, it is now taking longer in individual villages for additional cases to appear. That is, the intensity of transmission even in individual villages is declining quite dramatically. What we are seeing is therefore not a phenomenon where there seems to be an overall calm, but where there are storms brewing in individual villages underneath. Rather, the calm is genuine and widespread, affecting almost all villages. This is also reassuring. Taken together, therefore, if we were to assess the situation afresh today, we might conclude that VL is not a problem of public health concern, even if the formal definition of elimination has not been met, and that we are unlikely to see significant resurgence anytime soon. We would have been far more confident of making such definitive statements had we known how we got to this point in the first place. Unfortunately, we don't know for sure. Of the two intervention tools that have been applied widely, we have supported the IRS program quite intensely, and we have looked at the data very closely to understand the relationship between IRS and VL incidents. And we haven't found much evidence of an association, as we have reported earlier. As regards timely diagnosis and treatment, we are definitely vastly better off than ever in the past. Compared to the period before the last peak, the time to diagnosis and treatment are orders of magnitude lower, and the diagnostic and treatment modalities available today are far superior. So this intervention has definitely worked. However, we must keep in mind that effective diagnosis and treatment has become widely available only since around 2012, by which point we were already at less than half the peak incidence. That is, we caught the epidemic on the downstroke with some effective tools. Are these tools sufficient to prevent the next resurgence? We don't know for sure. If there is resurgence, the reservoirs is likely to be one or more of these. We are aware of that. Most PKDLs are macular, but they are unlikely to be potent transmitters. We are not consistently finding VL case clusters around known macular PKDL cases. HIV VL are known to be potent transmitters, but they account for only a small fraction of all cases. As we know, asymptomatics do not transmit efficiently, but we do not know whether individuals infected in the past may present as cases in the future. We need to be alive to that possibility. And we also need to take seriously the possibility that animals like dogs might be the reservoir accounting for apparently sporadic cases in regions that have very low incidence, including in South Asia. There is some evidence pointing to this, which must be followed up. What all this does point to is the need for continued close surveillance to see which of this is the bigger threat. What about geography? Are we in a position to predict where future cases will be located? Quite remarkably, despite the changes in spread of cases and declining incidence, the location of future cases remains quite predictable. In a previous graph, we had seen that there is remarkable consistency in the proportion of cases reported from previously affected villages each year. We have attempted to create algorithms to put this predictability to practical use. This graph is from a recently published paper showing one such algorithm. For instance, if a couple of years ago we had picked villages in Bihar that had reported 3 or more cases over a previous 3-year window, we would have found 1,241 such villages. And these named listed villages would have reliably contributed almost half of all cases reported statewide over the subsequent year. We cannot say for certain uh, uh, which specific village will or will not be affected during a given year, but the degree of predictability that I just explained lends itself to some very interesting applications. For instance, it may be applicable for conducting a kind of targeted sentinel surveillance. Let's say, on the basis of past data until today, we identify a relatively small set of villages that are expected to throw up a significant proportion of cases for the next year starting tomorrow. If over the course of the next year we find that the proportion of cases from these villages is higher than predicted, we suspect resurgence, not just in these villages but statewide. Contrarily, incidence less than predicted will mean a high probability of no resurgence anywhere in the state. Given a limited number of villages, uh, a good quality active case detection should be feasible under even under program conditions. In case ACD is not feasible, well-conducted PCD in the clinics associated with these selected villages should also work. But of course, if both ACD and PCD fail, we will be in serious trouble. We'll miss resurgence. Which brings us to the point that going forward, we need a monitorable indicator of the quality of surveillance. The number of cases of prolonged fever tested with RK39 could be one such indicator. We would expect this number to be constant year on year, even as RK39 test positivity will fall with reducing incidence of VL. Constancy should reassure us that surveillance quality is adequate. Finally, if resurgence were indeed to occur, our best bet to tackle it would be ensuring timely diagnosis and effective treatment. In addition to the ACD and PCD discussed, maintaining the fidelity and integrity of information systems will be the most crucial. If its fidelity is lost, we will lose the innate predictability that comes from good data. Good quality surveillance will mean we are well stocked with all diagnostics and therapeutics, and that surveillance is integrated into mainstream health programs. Better diagnostics are needed for PKDL, relapses, test of cure, and even for detecting subclinical infection. Leishmanin needs to be made available for surveillance and research. IRS will need to be revisited. It's not a very reliable tool. So in summary, the program can move forward with the confidence that there is unlikely to be a resurgence in the next few years, and that we have the means of detecting resurgence early should it happen. Only we need to use our tools smartly. We need to revisit how we define elimination as a public health problem and also IRS as a core strategy. Research needs to intensify around reservoirs and transmission and continue the search for better tools. Speakers after me will tell us more about other ideas for surveillance. So I will stop here. Just to say that behind us, we have a large team that helps us learn everything that we learn from the field, as well as, of course, from the people of Bihar and Jharkhand. Thank you very much for your patience.
Good morning and good afternoon, everybody. My name is Christine Klotz. I work at the Institute of Tropical Medicine in Antwerp, and I will be presenting a study that was carried out together with our colleagues from Professor Sundar's team in Banaras Hindu University in Varanasi. And the study was about validating the diagnostic algorithm for the current low incidence setting in India. So the study on which the presentation today is based was published in Diagnostics earlier this year, so those who are interested in this topic can read the full text online as well. Now, as you all know, VL is on the verge of elimination as a public health problem in India, with reported VL cases at an all-time low. However, these extremely low case numbers also bring along new challenges. One such challenge is about the reliability of the outcome of the diagnostic algorithm. The diagnostic algorithm in the Indian subcontinent is based on suggestive clinical symptoms such as prolonged fever and splenomegaly in combination with a serological test, usually the RK39 rapid diagnostic test, with an estimated sensitivity of 97% and an estimated specificity of 90% to detect VL among clinical suspects. Now, the reliability of the outcome of this diagnostic algorithm depends on the probability that a patient clinically suspected to have VL actually has VL. This is also called the pretest probability. This pretest probability is again directly linked to the prevalence of the disease in the community. With VL becoming progressively rare, the probability that an individual presenting with fever and splenomegaly does not have VL, but instead has malaria or any other disease presenting with similar symptoms, is increasing, meaning that the pretest probability of the patient to have VL is decreasing. Now, on the graph on the right here, you can see that when the pretest probability goes down, the likelihood that a positive test really reflects disease also goes down. This is called the positive predictive value. So loosely translated, this graph shows that the fewer people in the community have VL, the less certain you can be that a positive RDT result in a clinical suspect truly reflects VL, and the higher the risk of obtaining false positive results. So with this study, we wanted to assess what point on this graph we are at now. Can we still assume that the VL cases identified at present are real cases, which would be the case if we are located somewhere on the left side of the graph? Or have we moved towards the right side of the graph with a pretest probability that has become so low that the algorithm would no longer be reliable? So the primary objective of this study was to assess the validity of the diagnostic algorithm for the diagnosis of VL in the current low endemic setting in India by assessing the positive predictive value of the algorithm. However, from the graph on the right here, you can see that the relationship between the pretest probability and the positive predictive value is also influenced by the specificity of the test used. So therefore, as a secondary objective, we also wanted to estimate the specificity of the RK39 RDT. So to assess the positive predictive value of the diagnostic algorithm at present, we recruited VL patients through 6 primary healthcare centers, or PHCs, located in the VL endemic states of Bihar and Uttar Pradesh in northern India. So all individuals presenting in one of these PHCs with VL suggestive symptoms between June 2019 and April 2021 were tested with the RK39 RDT. And then if the test was positive, these individuals were considered as VL patients in line with the diagnostic algorithm and asked to provide a venous blood sample to be tested with qPCR as the reference test for validation. And then the positive predictive value of the diagnostic algorithm was calculated as a proportion of VL patients who were positive with qPCR. And so here you can see what we found. A total of 74 new VL cases agreed to provide a blood sample for the study. So all of them diagnosed based on the diagnostic algorithm of clinical symptoms in combination with a positive RDT. And as you can see, of these 74 VL patients, 70 could be confirmed with qPCR, reflecting a positive predictive value of 95%. So that means that according to our study, 95% of VL patients diagnosed at the PHC level at present truly have VL, which was higher than expected. Then for our secondary objective, we wanted to assess the specificity of the RK39 RDT. So that's the ability of the RDT to correctly diagnose non-diseased individuals. For this, we carried out a serological survey between May 2019 and December 2020 in 7 clusters in Bihar and Uttar Pradesh. All individuals aged 2 years or above were tested with the RK39 RDT on the spot, and then those testing positive in combination with a history of fever for more than 2 weeks were considered VL patients and were therefore excluded in further analysis. But all the other individuals were considered as non-VL cases. And then the specificity of the RK39 RDT was calculated as a proportion of non-VL individuals testing negative with the RK39 RDT. And then this table shows the results of our survey. So as you can see, a total of 15,422 individuals provided a blood sample. As none of them reported symptoms suggestive for VL, all participants were considered as non-VL cases and therefore included in the analysis. Of these more than 15,000 individuals sampled, as you can see, only 39 tested positive with the RDT. So that corresponded to a specificity of 99.7%, which was also higher than expected. So summarizing our results, we found that the diagnostic algorithm is still reliable at present in India with a positive predictive value of 95%. In addition, the specificity of the RK39 RDT was higher than expected, namely 99.7%. And this second finding actually at least partly explains the first, because according to the literature, we were expecting the graph on the left here using a specificity of the RDT of 90%, but redrawing the graph with a specificity of 99.7% that we found in our study, we get the graph on the right, illustrating that with such a high specificity, we can indeed expect the validity of the algorithm to remain relatively high until quite low pretest probabilities, which is indeed what we have observed in our study. So where do we go from here? The very high specificity of the RDT that we observed in our study opens some new perspectives. For example, if the number of RDT positives among the general healthy population is so low, we could consider testing fever cases more early on, before the 2 weeks of fever or the splenomegaly that are currently required to be VL suspect and meet the criteria for RDT testing. So this would carry the potential to shorten diagnostic delays. Also, we need to monitor the use of the RDT in the current PHC setting, because if all the RDTs that are being used show a positive result, this most likely means that not enough febrile splenomegaly cases are being tested with the RDT, and that chances are high that VL cases are being missed, which is, of course, something that we want to avoid. On the other hand, we also want to avoid too many false positives, but the wider we screen, the lower the pretest probability and the lower the positive predictive value, making a positive RDT result less reliable, as we have just seen. So taken together, we need to find a good balance between screening widely enough on the one hand and avoiding too many false positives on the other hand. But in all scenarios, monitoring of the validity of the diagnostic algorithm and confirmation of all newly diagnosed VL cases will be crucial in the years to come. I would like to thank all the stakeholders who were involved in this study, Epco Haske from ITM, the teams from KMRC and BHU under the coordination of Professor Sundar, also the Speak India consortium within which the study was conducted, the Bill and Melinda Gates Foundation for funding of the project, and of course all the participants who took part in the study. Thank you. Good morning and good afternoon, everybody.
I'd like to thank the Core NTD and symposium organisers for inviting me to talk on vector surveillance in the post-elimination era. Now, the WHO Global Vector Response Guidelines aims at reducing mortality by vector-borne diseases by 75% and the incidence by 60%, and then preventing outbreaks and epidemics in all countries by 2030. This is to be achieved by the 4 pillars of action on top of a foundation of enabling factors in a country. And as we move into the post-elimination era, strengthening those pillars and the foundations are critical, and that includes vector surveillance. We know that controlling insects in vector-borne diseases is something that can have a significant impact on the overall disease burden. However, there's a lack of well-documented examples of the impact of vector control on entomological and epidemiological indicators in vishtrichoniasis, an area of research which is needed. However, strong circumstantial evidence does exist. For example, the malaria eradication campaigns in Bangladesh and in India during the use of DDT, IRS, significantly reduced and almost eliminated VL. Based on this evidence, in 2005, when India started its path down VL elimination, it adopted DDT IRS. No new entomological baseline survey had been carried out at that stage. In 2013, baseline data was collected during operational research, demonstrated high levels of resistance to DDT and poor quality IRS due to the mode of delivery. This resulted in a policy change by the program to an effective insecticide, alpha-cypermethrin, and the use of compression pumps to improve the overall quality of spraying. Routine regular surveillance at sentinel sites is needed by any vector-borne disease control program. And in the elimination program for VL, we established 8 in the region. Now these sites can be used to see temporal trends, determine impact of control, and to monitor changes in vector behavior, etc. over time. Now this was a vertical system, only focused on VL, established in 2016, with data still being collected today. And if we look at some of that data, since 2016, sandflies have remained susceptible to alpha-cypermethrin, which suggests that it is still effective for vector control, but are highly resistant to DDT, which then suggests that compared to the work that was carried out in 2013 to 15, the IRS program is effective today. We have seen a decline in sandfly abundance over time. However, we have also seen this in some of our non-IRS sites, so we're trying to investigate and understand the reasons why that might have happened. Key is the xenomonitoring that we've carried out at the same time. Very low numbers of positive sandflies for L. donovani, and in the past few years, 0 have been detected, suggesting that the transmission cycle has been broken, and perhaps this is enough to suggest that elimination of 0, as we have in malaria, should be the target. So just before the change in IRS policy, the program had made significant changes in active case detection and treatment. As with other vector control programs, effective clinical and vector control is needed. And as we can see, this data, the case instance, is actually just for the sentinel sites, but it's well below now a case instance of 1 at all of the sites that we've been monitoring. And in India, very few blocks are actually with an instance above 1 now, so the target of VL eliminations has almost been met. Part of the GVCR is intersectoral collaboration, and information technologies can help disease control programs to better manage and analyze their data, and thus enhances the ability to carry out continuous surveillance, monitor interventions, and evaluate the control program's performance. In India, we use the DDMS to directly input entomological data. However, we were also able to import data from other partners and databases. This includes data from CAMIS and IRS coverage data from the States. And while this allowed for quarterly reports of a holistic nature to be circulated to stakeholders, the database is updated live and can be accessed by people as and when needed for decision making. So this data will obviously go to support India in its WHO elimination certification, which is great. But post-interruption of transmission, these sentinel sites should be maintained as they are highly receptive sites to outbreaks and also to see what occurs later. But as elimination is reached, the program will need to orientate towards an enhanced surveillance system building on this platform. And how do we do that in an effective and a sustainable way is probably some of the key questions that need to be addressed. Now, one way in which we're taking this forward in India is that the surveillance platform that was set up as a vertical system. However, in the northeast, India has 6 vector-borne diseases, including 3 that are undergoing elimination: lymphatic filariasis, malaria, and VL, as well as dengue, which is having seasonal outbreaks. However, no continual surveillance exists except for VL. By creating an integrated entomological surveillance platform for 6 diseases, the value of the sentinel sites increases and the costs can be shared. These sites then offer unique platforms to carry out epidemiological, entomological, and operational research. Currently, we are busy evaluating some of the best methodology for that surveillance, looking at different trapping methods, CDC light traps, BG sentinel traps, etc. and this is just some data we have collected recently. This is an example of understanding abundance and how it allows us to understand the receptivity of the environment to key vectors, and the trends allow us to see when vectors are most prevalent and when best to control them. And if we know that, we can potentially target multiple vectors with the same intervention. So knowing that our vectors are actually all prevalent mainly around this time period of January through to October, this is the best time to be potentially attacking all vectors at once and controlling multiple diseases. Understanding resistance is also critical along with the vector behavior, when, where they bite, where they feed, etc. If vectors share the same resting site and are both susceptible to one insecticide, then it may be feasible to control both simultaneously, again adding value and sustainability to the surveillance program. As we move towards the elimination goals, these sentinel sites need maintaining, however the frequency of sampling may be reduced. Initially, sandflies had been caught bi-weekly using CDC light traps in houses. However, that could now be reduced to even monthly or potentially bi-monthly, and also the time period in which we're sampling, as we know that the sandflies are only really available for collection between March and October. There is a new need for a development of sampling frames around that to take that forward. Resistance needs to continue on an annual basis, because insecticides may need to be used for vector control either in a reactive system or ad hoc treatments. Vector behavior may not change much on an annual basis, however we still have gaps that need filling in. As elimination has almost been met, knowing what the onward surveillance will look like is a discussion that needs to be had now, and we need to start meeting to determine that. And to achieve these goals, we need capacity in country and local ownership. And we're looking at now developing a standard course focused on field teams and the programs. So not just hiring more people, but also developing the material to train them and give them the capacity they need for developing surveillance for Aedes, Anopheles, Culex and sandflies for these diseases and how to control them, and the tools that could potentially support integrated entomological surveillance. And I'd just like to acknowledge our partners, the National Centre for Vector-Borne Disease Control in India and Care India, who've been our partners since 2013, and the Bill and Melinda Gates Foundation, who have been funding us for all of this work and make all this happen. And of course the teams that go around doing all the work in the field, great support team out there, both the field entomologists, the spray teams, the lab scientists we have. Thank you.
Hi, I'm Mary Cameron, and I'd like to thank Dr. Nupa Roy and the organisers of QuaranTD to give me the opportunity today, on behalf of Speak India partners, to talk about work that's led to the development of a point of need multiplex tool for integrated vector-borne disease surveillance. Now, some of our earlier work was using molecular xenomonitoring to try and define endpoints of VL transmission. Now, molecular xenomonitoring has been used for lymphatic filariasis surveillance, where thresholds of infection in mosquitoes have been previously quantified. However, these critical thresholds have not been quantified for sandflies and leishmaniasis. So that was our first goal. And this work was conducted by RMRI in India, Patna, and also by the London School of Hygiene and Tropical Medicine. So the objectives were, first of all, to sample as many phlebotomous argentipes as possible, and then screen these females in sites that either had no previous history of VL transmission or sites that had ongoing VL transmission, and those that had previous transmission but not ongoing. And we were using these molecular xenomonitoring data, looking at Leishmania donovani infection rates in sandflies, and also comparing it with the series of AINTS data that was being collected in another Speak India project at the same time and place. And this was to look for those critical thresholds, but also to improve transmission models. So our study was conducted in Bihar, 5 different districts in Bihar, and 12 different villages, spanning these 3 transmission strata. And as I mentioned, some of our households overlapped with the series of AINTS project. And we were using CDC light traps placed indoors to capture Phlebotomus argentipes twice a month over a 2-year period, because this collection method was the best in a previous pilot study. And these are our results. So over a 2-year period, which was required to collect our target number of 3,750 females to detect a difference between the 3 different transmission strata. And this period of collection was interrupted by flooding and also by the COVID pandemic. But we did eventually collect as many Phlebotomus argentipes that were required. But for each Phlebotomus argentipes female, I want to draw your attention to the fact that we collected 5 times as many mosquito females, which were incidental captures for our particular study. And the reason I want to draw your attention to that will become apparent later on in the talk. But during this 2-year period, we stored our samples in the RMRI freezers, and then we dissected, pooled and tested these Phlebotomus argentipes female pools for the presence of Leishmania donovani DNA by 2 protocols of qPCR. But we found that none of our pools were in fact positive for Leishmania donovani DNA. And similarly, I know that Mike Coleman and his team also found very low infection rates of Leishmania donovani and Phlebotomus argentipes during their longitudinal sampling. So in this approach, in times where there are low endemicity, was not useful, and it was challenging and very resource demanding. So you will see that each time you set up a light trap, it can cost nearly $9, and it costs about over $3 for collecting each individual Phlebotomus argentipes. Extracting the pools of DNA from the pools of Phlebotomus argentipes was also a significant cost. So going forward, we wanted to develop a way that we could reduce these costs and to reduce the time burden of a molecular xenomonitoring study going forward. And to do this, we developed a multiplex tool for detecting both DNA for different pathogens such as parasites and RNA for arboviruses. And this work was headed by Professor Susanna Campino at the London School of Hygiene and Tropical Medicine. So what we wanted to do was to exploit the fact that an insect biting on a human, if it was particularly a human with a particular disease, serves as a biological syringe. So even if it's not the natural vector of a particular pathogen, but a biting insect, be it a sandfly or a mosquito, has recently blood fed on someone with a particular disease, then we can screen all of the blood-fed insects within a collection, all of the mosquitoes, all of the sandflies within that collection, for pathogens which they may not be the natural vectors for. So we could screen in a particular area for lots of different pathogens at the same time. So they could be emerging infectious diseases such as dengue, Japanese encephalitis or chikungunya, or parasites that are under elimination, such as those that cause visceral leishmaniasis, lymphatic filariasis, and also malaria. So there are two different ways that you could isolate DNA or RNA. So you can use something like a QIAGEN kit and then screen using qPCR, which is generally done for molecular xenomonitoring for lymphatic filariasis. Or you could use crude extracts and use RPA, recombinase polymerase amplification, to detect the different DNA or RNA. Now, what we wanted to do was to look for multi-pathogens of interest, and in the Indian subcontinent, those pathogens include different malaria plasmodium species, Wisharia bancrofti for lymphatic filariasis causing agent, different viruses, and also Leishmania donovani. Now, the advantage of RPA is that you can get rapid amplification very quickly and at temperatures greater than 21 degrees C. You don't need sophisticated machinery. You don't need to bring it back to the laboratory for qPCR analysis. And it's resistant to crude samples, so you can do it in the field using sandfly and mosquito pools in the field. And the molecular reagents required are applicable for field use. And Suzanne and the team have developed this, have optimized this lateral flow test, just like a COVID test, for 4 different pathogens. So they've done it for dengue, pathogens 1 to 3, and also serotype 4. They've also done it for malaria, lymphatic filariasis, and Leishmania donovani. But they can also detect, using a similar system, different sources of blood meals, different species identifications, and also KDR resistance mutations and vectors too. Now, there are cassettes now where you can use 3 different lateral flow dipstick tests according to the program requirements. So these can be done in advance in the field. And that's exactly what we're doing at the moment. So with our collaborators at ICDDRB, we're comparing the efficiency of RPA lateral flow test assays with traditional qPCR in a field setting. And we're doing it in 4 different study areas. So we're doing it in areas where we're targeting visceral leishmaniasis and PKDL and sandflies. We're doing it in dengue in Dhaka City. We're doing it for lymphatic filariasis, and we're also doing it for malaria. And we have enrolled index cases of each of these different types of diseases, and we're sampling in those index cases households and in surrounding households to screen all vectors and non-vectors, so anything that's recently blood fed, for each of these different pathogens. So we're going to compare the sensitivity and specificity of the RPA flow tests and also qPCR, but we're also comparing the cost and the timeliness of results. So in the field, we'll be sampling the different insects using a different variety of different trapping and aspiration techniques. We'll be pooling in the field. We'll be performing crude DNA extraction using lysis buffers. We'll be testing those crude extracts using RPA cassettes in the field. And then we're going to be transporting those same extracts back to the laboratory, then performing QIAGEN extraction, qPCR, and we're repeating the RPA as well. And we're using a costing tool similarly described for looking at each of these different activities to compare the cost. And we're using handheld devices to report back immediately the results of the crude RPA analyses. So in the future, We will have to optimize this point of need test further, but we also want to make sure that it's suitable for programmatic use. So what we envisage is that we can use anything that's blood fed for screening a variety of different pathogens and being able to report back those results to the key stakeholders, either centrally or also to different health centres, and to engage the community in these activities. But in the discussion going forward, I think that we need to think about where would be the optimal sentinel sites according to programs' needs. We need to have context-specific frameworks for sampling, and we need to make sure that it's integrated with the program's dashboard to ensure rapid response and to think about how to best involve the community going forward. I'd like to thank the National Centre for Vector-Borne Disease Control and also the Indian Council of Medical Research for their governance. I'd like to thank the Bill and Melinda Gates Foundation for their funding, and I'd like to thank all of the partners involved in this research, as well as the field teams and study participants. Thank you very much for your attention.
So I think all the presentations are over.
Yes, Dr. Roy, I think everything is over.
So now we need to discuss how to go about. Another thing I would like to mention here, in the partners slide, I purposefully did not mention WHO's name because WHO I don't consider as a partner. This is centered for the program. Right hand, if right hand is the national program, left hand is the WHO, because all partners may not be there, but WHO will be always there as long as the institute is there. So that's why I did not write there. And now we can discuss. The floor is open. Patrick. Yes, Patrick.
Yeah, thank you so much, Dr. Roy. And I want to thank all the speakers for really terrific presentations. You know, I can see the field utility of each one of the approaches that you've described. And my starting question maybe for the four of you is, how do you put all of those pieces together? Are there settings in which all of the testing algorithms, the active case detection, passive case detection, the entomology, and all of the new diagnostics are all being used in one setting? Because it seems to me that there is really a potential here for all of these tools to really be used very effectively to extinguish any residual transmission that you may see in different sites.
Yeah, so I think we have the surveillance sites that are going on at the moment, and we actually really wanted to test Mary's tool inside those sites, because we're doing currently xenomonitoring by PCR, and obviously a simple tool like that we can do in the field would alter what we're doing. We are already working with CARE, and our Sentinel sites contain all the case data and instance data which comes from CARE through the CAMIS system that they set up. And would obviously love to work with Kristin on having that sort of modeling going on in our sites to see what's going on as a holistic view.
Yeah, I fully agree, Mike. We've been discussing this already, how to integrate more the vector part with the human part. I think we're not yet there, but there's definitely plenty of options. I think one approach we have been exploring a little bit is monitoring of transmission rather than just the cases being reported. So that would be one interesting way to go, to really put vector and human layers together and see how best to use both. And yeah, what indicators would be best to follow up going forward. Much work to be done, I think, though. This hasn't been, yeah, we don't even have the tools for the human part for this as well, to monitor really infection rather than cases. So I'm happy to hear you say that, but it would be an interesting way to move forward.
Definitely.
I think part of the hope here is that we do find ways to move forward by putting all of these ideas together. Mary, I didn't mean to cut you off.
Yeah, that's quite all right, Patrick. I think what we need to do is get a better understanding of the programme's needs. I think that we're all moving forward from a vertical programme. We all started off thinking about surveillance tools and also how to do active case detection for visual leishmaniasis. But over the years, we realised this isn't sustainable as a vertical programme. It has to be an integrated programme, different diseases and how to target those. So I think moving forward, we've all got different approaches, but it all depends on the programme's needs and priorities. And that's what we need to do, is synthesise this information, think about the sentinel sites, not just for visual leishmaniasis, but all of the vector-borne diseases and maybe other diseases that aren't vector-borne that need to be targeted. And Christine, in addition to the diagnostic algorithm, they were also working on serious surveillance for visual leishmaniasis and other diseases. And I think it's sort of using these complementary sort of techniques in the ultimate place. So it needs standing back and thinking about where we need to be conducting these studies, for what purpose, to reduce the resources that are required from the programme, because it's a programme that will be taking this forward, but also to think about how to optimise the community in this surveillance as well, because I think we need community involvement to make this a success and sustainable.
Just one quick word. So, but I am completely in agreement with what the rest have said, and I think there is a lot that we can do together. In fact, as explicitly as a part of the support, the Bill and Melinda Gates Foundation, the project that we have with them, the grant, that has an explicit mention of the fact that because we are helping the program on the ground scale up and make things effective operationally, one of our specific roles is to in fact take up good ideas as come, for example, from all the work that Speak is doing, and see how those ideas can be actually integrated completely into the elimination program operationally, so that it sees the light of day and reaches the people that it needs to. So that's a specific role that we are in fact been told to play, and we are doing that. Thank you.
Thanks very much. Back to you, Dr. Roy.
So, anyone would like to speak about the presentations made? Lastly, I will say.
Dr. Nupur, I see that there's a few questions in the chat. Maybe we can go through those.
Yes. Is program thinking to switch the insecticide to avoid development of resistance? Yes, that is the question. The question is very pertinent, as during 2015-16, we switched over to DDT. And DDT prior to that was used for almost 50 years. After that, it has become resistance. But as per my knowledge goes, as per WHO, that insecticide should be changing within a span of 3-4 years to avoid resistance. So if and for that, for government to proceed forward, we need evidence, and RMRI and LSTM, they are creating data, and in the event when they publish that that Santai has got resistance against SP, then definitely we need to change. And here I would like to come to Dr. Sridhar's presentation that, and earlier also we talked in many instances that when to stop IRS. Because IRS is extensive, huge, both financially and labor exhaustive also. And now he has also shown that the correlation and the dividend what we are getting out of this vast intervention is not that dividend yielding. So, but any vector-borne disease control program should have at least two strategies, that is to manage the patients and to attack the vector. In that case, I would like to request Dr. Sridhar how, and discuss with other experts as well, what can we do? Because in my recent concluded visit to Jharkhand, in Littipara, as far as I remember, there is a new village, almost name is Vishwanathpur. There was 2 patients. So we cannot just delete IRS blanketly, but some intervention to attack the vector has to be there. So, Dr. I would like to hear from Dr. Sridhar. And another thing, Dr. Sridhar is saying that yes, there is. We can assume that there is no threat to re-emerge or to get more BL cases. But the epidemiology is like that. If things goes right, I will be the happiest person, because I am every day at night thinking of elimination of Kala-Azar. And so, yes, that is our wishful, that is what Dr. Sridhar said is my wishful thinking and desire as also. Because though it is 2030 WHO's roadmap goal, but for India it is 2023. So, and so when to stop IRS is a big question to me. I am not an entomologist, but I need help of Mary and others, Coleman, and to how to something. I think something must be there. Like this Vishwanathpur, the new village never reported a case, never since 2005. So how to deal these areas? There is these patients. One patient has got travel history to an endemic area, but the second one has not. So it is evident that the second one got infected from the other one. So that is there, and another issue is we are talking about integration. Yes, integration is always very good. But if we compare the burden of malaria or lymphatic filariasis or dengue, VL is very low. So my fear is that in the event of integrating for all vector-borne disease control, whether VL part is not getting diluted or attraction may not be there. So that is my inner feeling. So this is a public health program. We will be working all together, and I am hoping that it will be. And another thing we talked about in many forums, we are living cases less than 1 per 10,000 population at block level. So we are living focus. So anytime it may so happen, like one example, Dr. Sridhar must be knowing, in Sheikhpura, all on a sudden 56 cases. So these things are behind my mind. Is I am rather scared because though it is my dream that it will be eliminated, but and he has also talked about the reservoir of others. As I remember in Kathmandu Artec, Dr. Shourab was also there. I presented the Kerala map, and almost every year, sometimes alternate years, there are one or two cases reported from the forest fringe areas where the persons they are not linked to the stream of life. So how come they are getting infection? That is also very important. Otherwise, now I will like to hear from you and Dr. Sridhar and all the partners giving immense support to Kala-Azar program. What we are seeing today is their concerted effort. And when I joined in 2013, only the care was there and LS team was doing separately. And after that, we came to on the same board and we are working. Thank you for all your support. But these questions are to be and regarding IRS stop. So I think we need to, because the technical strategies mainly led by the WHO. So if
Dr. Roy's frozen.
I think we temporarily lost her.
Okay.
Yeah, okay. So I think one point that she was referring to, a couple of points at least she referred to me a couple of times. Let me just respond to those specific issues. So we have had a lot of discussion offline about
because vector control, I may be wrong, but what I learned that there should be a
Sridhar, I think you can carry on.
Now the floor is yours.
No, I was just saying we've had a fair amount of discussion offline among various partners about IRS and its impact, and it's something that we had at one point of time also proposed that through ICMR, in fact, that we should have a well-controlled trial to test the effectiveness of IRS in reducing VL incidence over a certain period of time. Unfortunately, the incidence of VL these days is so low that it falls well short of the sample size requirements that we would have to, show a small difference, and we don't have a big difference that we are fairly sure. So, IRS is going to be it's a call that we'll have to take without adequate evidence. And what I'm only suggesting is that even if we stop, given that we are unlikely to see a resurgence in the near future, nothing much is lost. And in the meanwhile, we could think of what else we can do, especially of the kind that we are doing right now. One thing is indoor only. So whether indoor alone is sufficient, especially in areas like Bihar. Number two, whether we need to spray a village for 3 years after the last case, because that strategy implies that asymptomatics transmit, and we don't have any evidence to say that they do. So at the very least, what we could simply do is to bring down the intensity of IRS to good quality spray done after specific cases occur in villages. So as soon as a case happens, go spray, that is the only time that you have some hope that there are infected sandflies that you can destroy, and that therefore there will be no transmission thereafter. But then the question there still remains: what if there is outdoor transmission happening, and what are the means, modalities that we have for controlling vectors outside the home? So that's as far as IRS is concerned, and I think it merits a good substantive discussion. As Dr. Roy pointed out, there's a lot of investment happening in IRS, both operational as well as the cost of insecticide. Also, in case there is resistance to alpha-cypermethrin or synthetic pyrethroids developing, the next class of insecticides is likely to be far, far more expensive. and that is something that we should be cognizant of. So, so given all of these realities, IRS is really worth something that we should be looking at, even though there is no straightforward possibility of conducting a trial. So this is one part of it. The second, of course, is about the resurgence. My only point there was, yes, are we confident? We are confident because of the reasons that I outlined. Looking at past data, there is just no way I can see that there will be a resurgence anytime soon or in any big way. And even if there is a resurgence, we have enough ability to prevent mortality and therefore control it as a public health problem. So, and a lot of the morbidity, because we are able to detect cases quite early. And as what Kristen showed is that at least our diagnostic, the primary diagnostic test that we have is still pretty good, even at this stage of the epidemic. So I think we are pretty good in being able to predict that, and we should take it with that confidence. Given this confidence, therefore, let us take a look at all the tools again, is what my proposal is.
We can't hear you, Dr. Roy.
Yes, I think Saurabh raised hand. Yes, Saurabh. Unmute.
Yeah, yes. Can you hear me?
Yes.
So first of all, congratulations to everyone for the wonderful presentation and discussions. So I was very much keen to discuss few things. So one is when to stop IRS. And if you look at the vector control intervention data, which is available of last 10 years. So 10 years back, around 10,000 villages were being sprayed. But if you look at 2021, 2022, I think now the number of villages which are being sprayed are almost 1/3 or less than that. So which means that you are within the program already have set certain criteria based on which you are stopping IRS in a set of villages. Now, we asked this question to modelers, and the response we received from modelers. So the question we asked, what could be the transmission scenario where the IRS can be stopped, a decision to stop the IRS can be taken. And the second question was that what is the likelihood of having outbreaks related to those transmission settings. And the response we received was that it is very difficult to recommend or set the criteria when to stop IRS. But all they could suggest that IRS should not be stopped abruptly. You will be happy to know, and Dr. Nupur is one of the contributors in the manual. So we have studied this carefully, especially the example from India. And we have proposed certain criteria based on which you can take a call, take a decision when to stop IRS. And we are going to publish this global operational manual of leishmaniasis vector control. It will be available in 4 to 6 weeks time. So that's one thing. Second, I would urge all the experts to reserve their opinion about the impact of IRS. And this question has been troubling us also. the vector control intervention, which was in use for several decades, almost more than 4 decades, is now proving to be inefficacious or is considered less efficacious or not efficacious at all. So you will be happy to note that we are constituting a guideline development group, which will look into all the evidences on the effectiveness of indoor residual spray. And we will come with a very clear recommendation for the national programs, especially the Southeast Asia region. And lastly, I would say on the resurgence aspect, I think active resurgence will depend on, so I have interpreted that that we are talking about finding a new case. Therefore, we are talking about a confirmed VL case in those localities where, or in those villages where the incidence has gone down significantly. And in absence of any kind of surveillance test available, our detection will be entirely depend on the case detection activities. Therefore, the likelihood of resurgence or the risk of resurgence remains there, even in those settings where the transmission has gone down recently. If the sensitivity of surveillance goes down, and this will be felt more in those areas where the incidence has gone down earlier than other areas. And you can find this from one example of Uttar Pradesh, which used to report a good number of cases, but from 2008 onwards, between 2008 and 2013, hardly any cases were reported from those 10, 11 districts. And all of a sudden in 2015 or 2016, one district reported almost close to 120 new cases. And that was because the perception among the health workers was that there won't be any new cases occurring in those villages. And that is the biggest challenge with the national program, that when the elimination target is achieved and partners are not actively engaged in the case detection activities, also in the surveillance and monitoring activities, how within the health system there is enough capacity that these cases are not missed. And that is the biggest task for all the partners, that before they stop their activities or reduce their activities, they pass on this skill to the general healthcare workers. And very lastly, on this animal reservoir, I think presence of infection in a particular mammal species, even in large numbers, does not indicate that it is a reservoir host. Therefore, a lot of studies need to be undertaken for the incrimination of reservoir host. So our advice is to look this aspect very carefully. because all those criteria need to be followed for labeling a reservoir host, need to be followed. So those are some of my reflections on the presentations. Thank you.
Thank you.
Yeah, thanks very much, everybody. I think that we are over time at this stage, and I realize that many people will need a bio break before getting into the next session. I want to just thank all the speakers for really terrific presentations. So thank you so much, and we'll hope that we can continue this conversation in some form.